My name is Andy, and today we are going to talk about a critical medical emergency, esophageal varices. This is a condition, while silent in its early stages, can present with life-threatening hemorrhage, and it has the potential to be fatal with a mortality rate of 15 to 30%. Our role in the pre-hospital environment is often the first and most vital link in the chain of survival. My goal today is to give you a clear understanding of the pathophysiological reasons behind this medical emergency and equip you with the how for immediate and effective pre-hospital care. To manage this condition effectively, we must first understand the core problem. Esophageal varices are pathologically enlarged veins located in the submucosal layer of the lower third of the esophagus. Think of them like varicose veins, but located internally, often hidden until they rupture. Their formation is a direct result of portal hypertension. Within the system's normal pressure, that is between 1 to 5 millimeters of mercury, veins remain in a state of homeostasis. When the pressure starts to elevate, equal to or greater than 10 millimeters of mercury, the risk of varices developing increases. As the pressure continues to rise, equal to or greater than 12 millimeters of mercury, the chance of rupture increases substantially. As the portal vein collects blood from the gastrointestinal tract and delivers it to the liver, this process can be easily disrupted by liver scarring, also known as psoriasis. This disease is the most common etiology by acting as a major roadblock, impeding blood flow through the liver. Depending on the advancement of the underlying liver disease and risk factors, which are here, the mortality rate of an acute esophageal varices bleed can fluctuate between 10% in early liver disease and up to 70% in advanced stages. With these increased risk factors, they have a higher likely of reaching this 70%. As liver cirrhosis is diagnosed, the patient is often briefed on an increased risk of varices developing, and the patient will undergo routine endoscopic examination to monitor and diagnose. It is important to note that an endoscopy is a gold standard and preferred method of screening, and that can provide a detailed examination and provide a grade or classification. The most common and universally endorsed system is the Broveno-Census classification. This includes the number of strands, location, and presence of red color signs. In this endoscopy pictures here, the top image is early stages with minimal reaction there to the veins, and this one is late stages where there are multiple varices and red color staining found. When the primary route is blocked, the blood has nowhere to go. It backs up in the portal vein, forcing the body to engage compensatory mechanisms that involve the formation of collateral vessels, aka portosystemic shunts, to assist with lower pressure pathways for blood to return to the heart. It's a physiological bypass, but one with a potential fatal flaw. The redirected blood fills smaller, thin, delicate veins in the esophagus, like these ones, that were never designed to handle such high volume and pressure. These veins balloon and swell, becoming fragile varices, primed for rupture. The rupture can be triggered by a sudden increase in system pressure, perhaps from coughing, straining, or vomiting. While cirrhosis is the main culprit, it's important to remember that varices can also be caused by non-cirrhotic conditions, such as blood clot or a thrombosis in the portal vein or splenic vein, and can also cause a backup of blood to form these varices. Oesophageal varices are typically silent until they bleed, at which point the patient's presentation is often dramatic and immediately recognizable. The most common signs of a variceal bleed are gastrointestinal hemorrhages. Hematemesis, the patient is vomiting blood. This can be a large amount of fresh, bright red blood indicating a rapid active bleed. Or the more subtle coffee grounds, appearance from partially digested blood. A small bleed from digested blood can pass through your stools in the form of melena, and this is partially oxidized and vomiting or pass through the GI system. In cases of severe blood loss, the patient will rapidly develop signs of hypovolemic shock. This is where we can do the best to assist the patient within the pre-hospital setting. Remember that the blood's compensatory mechanisms can initially mask the severity. Don't wait for hypotension. Look for the early signs. As a quick reminder, the key signs of hypovolemic shock to look for on road are tachycardia. An increased heart rate is the body's first response to maintain cardiac output in the face of falling blood volume. Tachypnea, rapid, shallow breathing, is another compensatory response. Altered mental status, confusion, anxiety, or lethargy can be early signs of reduced cerebral perfusion. Skin changes, pale, cool, and clammy skin due to peripheral vasoconstriction. Hypotension, a drop in blood pressure, is a late sign of significant blood loss. Crucially, variceal bleeding is often painless. The absence of pain should never be the reason to delay treatment. Also, be alert for associated signs of underlying liver disease, which may provide clues to the etiology, such as jaundice or yellowing of the skin, ascites, increased abdominal fluid, and general weakness. Not all gastrointestinal bleeding are caused by varices. Some potentially differential diagnoses are ulcers, gastric ulcers, cancer, Mallory-Weiss tears, tube trauma in the presence in the hospital, or foreign object trauma. Attempting to gather a detailed medical history is essential. Past medical history, important. Our management strategy is to focus on the basics, the ABCs: airway, breathing, circulation, and ultimately transport. This is vital to the survival rate of our patients pre-hospital. Early clinical support is recommended, either ICP or MedStar, depending on locality. ICPs or MedStar. In Adelaide, you may be able to get both. Airway and breathing, this is our absolute priority. A patient who is vomiting large volumes of blood is severe risk of aspiration. Secure the airway and, if necessary, manage the patient's breathing with supplemental oxygen. Basics resus up here. Circulation and fluid resuscitation is the goal to correct hypovolemic shock. We are to establish bilateral IV access with large bore cannulas. To begin fluid resuscitation, here is extreme caution, because this is a delicate balance, and excessive fluid administration can paradoxically increase portal pressure and worsen the bleeding. The goal is to achieve hemodynamic stability, not to fully replace all blood loss. The target here is between 90 to 100 millimeters of mercury systolic blood pressure. Transport requires definitive hospital care with a gastroenterology and interventional radiology support. Our role is to provide rapid and safe transport to the facility that can offer advanced care, including endoscopy, where the bleed can be treated directly. It is essential that we notify the hospital prior to arrival with an ISBAR handover. Within Adelaide, the preferred destination is the RA or FMC. But if the patient is hemodynamically unstable, with continued abnormal physiological parameters and fluctuations in presentations, transport or divert to the closest ED with early notification. Bleeding esophageal varices are critical, high acuity, low frequency event. The bleed is sudden, massive, and can be fatal. Our pre-hospital response, from rapid recognition of the subtle and overt signs of shock to be prompt. Judicious fluid resuscitation and swift transport is fundamental to a positive outcome. By understanding the underlying pathophysiological reasons, we can be better primed and anticipate the downfall, the patient's clinical trajectory, and deliver the timely, effective care that this life-threatening emergency demands. Thank you.